The Trust is pleased to once again partner with Dr. Sarah Smucker-Barnwell and Margot Adams-Larson to present these telehealth community chats. They have done a tremendous job with this series, and I know I and our policyholders appreciate their expertise and the time and effort that goes into putting these together. I hope you enjoy and benefit from our telehealth community chat today. Please join me in welcoming Dr. Smucker-Barnwell and Adams-Larson.
Thank you so much, Dr. Davis, and thank you to Dr. Martin and all the amazing and talented staff of the Trust. And thanks to everyone attending here today. We appreciate your spending our time with us. And hi, Margot, how are you?
I'm awesome. How are you, Sarah?
Well, I love doing these chats together. I'm excited to learn what questions we may have. And of course, we've taken questions from the prior chat as our topics for today.
And before we get into things, we do have a few reminders for our folks watching and participating. We really welcome your questions to drop in the chat. If you think of something afterwards, you can put that in the evaluation because we review through those to look for questions for upcoming chats. And also you can email us and they'll have a email for you to link into us in between the chats. We are thrilled to be a part of the Trust team and to be bringing the chats to you. I can't believe it's number 23. It seems like it was just yesterday when we started these, but these are quarterly check-ins, and we don't provide or prepare a lot of PowerPoint slides for these. They're very conversational. We mean to have conversation about the topics and be able to respond to the questions that we see in the chat and the questions that have come in. We endeavor to provide practical how-to information from an ethical clinical perspective. And oftentimes we find ourselves kind of transitioning our conversation through those topics as we go in responding to the questions that you pose and the questions we prepared. So feel free to email those in or drop in the live chat or Q&A today. And Sarah, I'm going to toss it over to you because I know we kind of had a newsy item that always we would head off with, but we've got a lot of news today. So I think we're kind of expanding that a little bit. We may have some questions related to that. So I'm going to toss it over to you to dig into some of those hot newsy topics for us.
Thanks, Margot. Lots of news. All news is good news. Well, maybe not, but today it's all good news. So we often give updates in this portion of our chat on PsyPact. Again, PsyPact is that interjurisdictional compact that permits psychologists to practice across jurisdictions when they have the authorization to practice interjurisdictional telepsychology, that permission provided through PsyPact and ASPPB, of course. So the big news here, PsyPact continues to grow. Officially, I believe there are 41 member states. Just today, additional passage of PsyPact in Mississippi. So, I think increasingly we're just seeing more and more participation. And the biggest news item I wanted to highlight relevant to PsyPact today is a pretty big deal. Legislative proposal in the state of California. And if passed, this legislation would mandate PsyPact implementation. And as I say, this is a big deal because California, is a state with, more psychologists than most others. And so it not being a PsyPact member has been meaningful because so many psychologists reside in California. Now, I don't want to represent this as a done deal. This is a hot debate. Advocates for its passage want to see this passed because it would provide that same flexibility, that capacity to practice interjurisdictionally that PsyPact member states have. Folks who do not want to see it passed would, cite concerns of psychologists coming from outside California into California. They would cite concerns of regulatory controls, from other governing bodies. And notably, folks who did not attend an APA accredited program are prohibited at this time from participating in PsyPact, and we're going to talk about that a little more today. So these are among the concerns that folks who are not necessarily in favor of the legislation, not opining one way or another as much as saying it's a big deal that this was proposed. And I'll be really excited to see what happens next, because I think for those remaining states who are not participating in PsyPact, I think the world is watching, to see what happens. So I'm eager to learn more. Second newsy update relates to cybersecurity. Many of us have been following along. There was a pretty notable cybersecurity event, Change Healthcare, which is a subsidiary of United Healthcare, really, really big healthcare provider in the United States, had a massive cybersecurity event that impacted provider reimbursements. And so the consequence of this was that many providers didn't receive payment for patients they had seen in a timely fashion, or in some cases, not at all yet, secondary to the cybersecurity event. The US Department of Health and Human Services released a warning to clinicians regarding these cybersecurity threats and gave some pretty specific guidance regarding being proactive and educating ourselves about cybersecurity threats. And the thing I always like to point out is, when I watch movies and television, cybersecurity threats seem very advanced and involving spies and, tremendously advanced technology, but most cybersecurity threats are very mundane. They're very everyday events that, they're easy mistakes to make, but they're simple mistakes. And what Department of Health and Human Services has highlighted are how to protect ourselves against some of these more simple mistakes. For example, they cited credential harvesting. It's a very fancy term for the notion that when we receive emails asking us to input credentials for logging into bank websites, or in this case, provider healthcare portals to receive reimbursement, anything that might be linked to your specific account and often financial data. These credential harvesting initiatives will seek to get people to hand over their credentials so that those perpetrating the cybersecurity threat can have access to that inappropriately. So HHS, Department of Health and Human Services, came out and said, be aware that you may receive emails inviting you to give credentials where you should not, and never give up your credentials unless you are absolutely sure, that you're in the right place to be logging in to an entity. Similarly, email bombing, they have pretty great terms, this HHS warning, the notion where we are just bombarded with emails, often with content like credential harvesting or others, but really it's the volume of the emails, overwhelming email accounts, overwhelming servers, in some instances, slowing traffic, and just generally wreaking havoc. And again, the thing to do about it is to alert our internet service provider if we receive our email through a work email that has, a hospital or a healthcare clinic or something like that, to make sure that the administrators of our IT systems are aware that this is happening and that we don't click on them and we don't give them our information above all. So this continues to be, really in the forefront of the news. And I think those folks working in technology will almost describe it, as just a battle happening in the background, in terms of just this consistent and rising threats to cybersecurity. So, in the immortal words of Mad-Eye Moody from Harry Potter, constant vigilance, we'll just be careful about what we click on. We'll be thoughtful about the emails we receive, and that will, be meaningful, in our efforts to protect ourselves. And then
Really
finally,
great, Sarah, I'm just going to interrupt because there's a quick question that we can easily answer here. When you're talking about credentials in credential harvesting, you're talking not about our credentials in terms of licensure or certifications necessarily. You're talking about the login process, the mechanism, either the name or the email that you use for logging in, and then the password. So just to clarify that, because that came in, I see, as a question.
Great point. Yes. I mean, I guess I'm not eager to give them any information, but mostly what we're talking about, usernames and passwords, because that's the information they really want, to capture the information they shouldn't have. Our final newsy item today relates to artificial intelligence, or AI, in the news. Many of us may have caught the CBS 60 Minutes special talking about generative AI. I think they particularly focused on one company, Wobot, that is a fully automated generative AI bot, chatbot, that is in trials right now, delivering cognitive behavioral therapy and other therapeutic services to participants. Limited availability for a product like that. I believe many of these are employer only or sponsored through healthcare systems at this time. That being said, it is on the rise, and I think, I don't know about you all, but I've been seeing on many of the listservs that I participate in a lot of discourse, a lot of discussion. And we're going to talk more about this in the coming chats, but I continue to invite each of us to be thinking about how AI is showing up in our practice, and how we want it to show up in our practice, the relationship we want to have with this technology. It is not, an if, in some ways it's a when, but really setting our own boundaries, understanding where we want to integrate, where we don't. I'm not going to go further than that, just to say, check out the 60-minute special if you haven't, it's worth seeing. And increasingly, this is just entering into our public awareness, the sort of central role that AI will be having.
There's so much, I think, that's coming down the pike as well. So we will keep our eyes and ears open for those newsy items. And as you mentioned, Sarah, we kicked off the news with some SciPac information, and I'll refer folks back to a couple really awesome webinar series that the Trust has held for SciPac for a lot of beefy, good, detailed information. But what I wanted to share today related to that SciPac topic is SciPac's one mechanism that can allow folks who go through that process to be able to practice interjurisdictionally, but it is not the only one. And I think really to help folks understand, there are alternatives if you aren't able to meet the requirements of SciPac, whether you come from a non-APA approved graduate program, or maybe you don't have the hours because the state you were licensed in didn't have that requirement at the time you got your original license. Maybe there's something that has transpired throughout your career, and there's just processes that don't line up to meet the requirements for SciPac. And so I wanted to dig in a little bit to understanding these topics of interjurisdictional practice and some of the different aspects that are available to us. And I want to start with going a bit farther back into the concepts of mobility and portability, because they're important to understand. They're not interchangeable. Mobility is when you have physical movement or a telepractice from one jurisdiction to another jurisdiction. Portability is when you're relying upon your original license or a license or credential in one jurisdiction for the basis of legal practice in another jurisdiction. And while they kind of sound like they might be similar because they do involve different jurisdictions, probably the easiest way to understand the differentiation is mobility is when you as a provider are physically traveling or your practice is traveling, where portability relates to the actual how you get your license or how you get to practice within those jurisdictions. So for example, if I am applying for licensure, if I'm licensed in one jurisdiction and applying for a license in another jurisdiction, I may be able to rely upon that licensure in my original jurisdiction in order to get a license in a second jurisdiction. They will say, oh, look, you're already licensed here. Okay, we'll count that as good and we'll move along. And here's another license for you. That allows me now to practice in both of those jurisdictions. Whereas mobility has much more to do with me either physically being in a different place or providing a service in a different place. So hopefully that distinction is helpful to think about as we're talking about SciPac, because in general, SciPac is talking mostly about providing that practice, not getting a secondary license in another jurisdiction. You're practicing on your original license. And I think that's a piece, Sarah, that you'll come back to later when we talk about supervision. But the idea here is if you don't, for whatever reason, meet the requirements for SciPac, maybe your jurisdiction isn't one of those, maybe they're one of those few left that isn't in SciPac yet. That doesn't mean that you can't obtain a license in another jurisdiction. What that means is you will have to go through the process of applying for a license in another jurisdiction. Allow that state licensing board to review what your requirements are if you meet the eligibility requirements. Prior to SIPAC, ASPPB had a process called the CPQ, which was and is still involved in the process of SIPAC, but it was meant to be kind of a bank of credentials and qualifications that you could say, hey, I have this qualification already, so that other state, that new state that you might be applying to, could see that, could verify that, and help that process go faster. And having just gone through applying for original or secondary licenses in new jurisdictions, some go fast, some go slow. This is an important thing to consider, because if it's something you're wanting to do on a more timely basis, you want to be thinking ahead and planning ahead with this. I strongly recommend looking into the Credentials Bank that is a program of ASPPB. And our great team behind the scenes can drop the link for that into the chat for you to grab. This is where you can hold and store all of those credentials that you might need for a future license application somewhere. So if you're a student or early career, this is ideal for you to get into now, because all of that is fresh information. For those of us who have been practicing a while and have to track down supervisors who've retired 20 years ago, it's a bit more cumbersome of a process, but I promise you it's worth it to have that information stored in a verifiable, trusted resource that can then be sent out to the different licensing boards that you may wish to have that information shared with. So that is part of the online application process for those states that utilize the ASPPB SciPro process, but it's also available to you to just have your credentials, and I'm using that term in the way of your career credentials, stored and available there. The things that you want to be mindful of when you're thinking about practicing and thinking about applying for licensure in other jurisdictions are your maintenance of the records for your education, for your experience, for your internship and training, practica, any other supervised hours. Some jurisdictions, if you're going to be teaching or doing research, they may want to have that information as well. You want to be maintaining those CE requirements and knowing what they are in other jurisdictions. They're not the same, by the way, in every jurisdiction. So the nuances of how many hours you need, how much can be online versus live versus, reading or journaling or, writing journal articles or books, or presenting, those all kind of vary from jurisdiction to jurisdiction. So you want to kind of stay current on what those requirements are. You want to really pay attention if you're doing any kind of forensic work, that you understand what those licensure requirements are and how it is you might go about obtaining or representing your licensure status if it's not within the jurisdiction that you are providing forensic work. And finally, we have the up and coming burgeoning aspects of psychologists with prescription privileges, and the nuances of how that will be related to mobility and portability are really important to pay attention to, and are going to be, I'm sure, part of this growing process of how we might be providing our practice depending on what it is we're doing within our scope of work and our scope of practice. So those are some of the things to consider. I'm going to break there and see if we've got questions on those, or move on to some of the questions we do have.
Well, I see a lot of great questions, and inclusive of people who we've gone through the process of multiple licensure. Several questions, it seemed, related to the notion of, is there a downside, to maintaining those licenses? And one person actually articulated, like, outside of the time, outside of the cost, outside of the CE requirements and the cognizance of the mandates of both jurisdictions and so forth, is there a downside to being multiply licensed?
I remember when we first started these conversations about telepractice and how could we make this smoother. And I remember forensic psychologists presenting on being licensed in all 50 of the jurisdictions of the US, and that it actually required hiring a full-time staff person to manage the continuing education and the licensure upkeep process for all of that. So it's not without consideration. However, if it's a scenario where you as a practitioner are traveling back and forth to multiple jurisdictions within kind of the work that you do, that might be an upside actually of having multiple licenses as opposed to looking at a SIPAC scenario or, trying to navigate kind of just practicing within your own jurisdiction. If, the downside truly is the time in keeping up. There's billing nuances, there's paperwork nuances of not just navigating the licensure side, but understanding the laws and keeping up with the laws in those multiple jurisdictions is consuming, because as we're hearing, we just have another state who's adopted SIPAC, which is great, but that means the law changed. And that means the law has changed in 42 states in the past several years. They're not static.
It's a great point, and I think, I don't know that it's even unique to, multiple licensure, because I think the same issue in some ways, I'm a SIPAC credential holder, and when the more states I practice into, the more I am expanding my necessary awareness and liability, frankly, around the rules that govern the jurisdiction into which I practice. And so I think it's a great point of consideration as you're highlighting, Margot, that we need to maintain our awareness of our ability to do it well. When I've worked in large telehealth companies, we had a legal staff, and that's all they did, was think about these issues and help inform the clinicians and make sure CE was in order and the forms were right and everything was done. When I'm in independent practice, well, I'm the team that does that. So making sure that I am, taking on a clinical load aligned with my capacity and resources to maintain awareness of the rules and adapt my practice in a way that's risk managed and thoughtful.
I would say one other piece is if you are truly licensed in those other jurisdictions, that you have the benefit of having your name known there, of having the information that they may share out to their licensees available to you, which you might not otherwise have as quickly or consistently. You have a way into the community of psychology practice within that other jurisdiction. And I think there's a lot of upside to that. There's a collegial realm that is not to be kind of forgotten in all of this, that those are important resources for you.
It's well said. I see quite a few comments, and I'd love to shout this out, that referencing National Register, who also provides us, with credential banking and verification. And it is another, excellent way to maintain awareness and history of your information in a way that's well established and well run. And so I know at the Trust, we have a great relationship with National Register, so I always like to highlight the great work that they do. Should we take a couple more questions before we move on? I saw a few questions in here asking about how we can tell legitimate emails, legitimate invitations to change our credentials from the bad. I have some thoughts, and I wonder if you do too.
Well, I think my number one thought is don't ever click the link in the email. Unless it's the email that, well, I won't even say unless, like it's so handy to have the email link, but the way to absolutely be sure it's not a phishing scam is to actually go to the site that you know of as the portal for your credential update, whatever that host is, and to go there and log in. Typically, those folks will have, a little notifications or while you were gone, and here's what you need to do since, you need to update your information or whatever, that will pop up. So I think that would be my number one tip is just don't click the link in the
That's
email.
mine too. Yep, because it used to be, and it used to be, I think that the efforts were less sophisticated. I think we've seen a lot of increasing sophistication in the last few years. There's a lot of money being invested in tricking people, so personally, if I get an email from my bank that says it's time to change my credentials, well, okay, I go to my bank website, and I use my credentials from there. And as you say, they've invested a lot of money to make sure that when I log in, well, poop, a little pop-up comes up and says, time to change your credentials, Sarah. But that's in the context of me intentionally logging into my bank's website, often with multi-factor authentication. It's a more secure process than clicking on anything from an email. So I'm with you. I just tend not to click on much of anything from an email.
I will say it is a hassle because you have to go back and find your resource, and
That's right.
but it is protection in that realm. So I think good advice.
Great. Well, I'm looking at the time. I'm cognizant. Shall we move on to some of the questions from last time?
I think so. Yes.
Well, the last time we met, we had some folks bring up the issue of non-compliance, patient non-compliance in a telehealth context. And, specifically how to engage in difficult conversations with our clients, especially when something is happening in real time, in the session. So, how can we manage it? To have the difficult conversation with the client about something that's going on that's not in alignment with what we discussed, that is maybe outside of something that's helpful to the clinical circumstance or something not covered in our informed consent.
Sarah, I think this is really a great question. And I want to pause here just to say, I'm noticing you have a visitor in the background, and
Yes, I do.
I want to be careful that we're paying attention to our conversation and the things that we're talking about, but this is super apropos to exactly what can happen during our session time with clients.
How coincidental, how wonderful. And what a nice job you did observing it in real time, calling it out and discussing with me as it was happening, because it's really easy to ignore these moments, right? Like, it's even gracious in general conversation, if something goes slightly amiss in our discourse, socially, if we're meeting, and I just kind of politely overlook it. That's considered good manners in many circumstances. And yet in a clinical environment, we as clinicians are trained to notice the subtle and sometimes very obvious things that are happening in our environment. And, you and I planned this silly vignette, but with the point of, we want to make sure we're calling it out in real time. When something is happening in our telehealth session that is not in alignment with what we've previously agreed to with our clients, or sometimes the law, it is our responsibility, legally, ethically, to note it and to talk about it. So I think I want to make a distinction that there are those instances where something's happening where we have a concern for safety. For example, I've had it happen, and perhaps you have as well, where someone comes into the room and they are angry, they're inappropriate, there is some type of assessment that needs to occur in real time. And I want to hold that separate, because I think what we were talking and the questions we received are a little bit different from are thankfully, these are the more common circumstance where nothing dangerous has happened, but something distracting has happened. Someone walks through the room, there's very loud noise. Someone is obviously texting on a phone, or, you can tell they're answering an email in the distance while they're talking to you. Our ability to be curious, to pause, to ask why, and to use those good clinical skills and lean into the moment. We want to revisit the reasons why we've agreed to do things the way we have. Perhaps in the case of privacy, well, I am bound by HIPAA to protect your privacy and confidentiality. And moreover, I question the extent to which we can be in a really engaged, focused conversation. If you got folks walking behind you, if you're on your phone, if you're typing an email, and so forth. So we want to revisit that agreement, talk about what we've agreed to and why, and get some insight into why isn't this working? Maybe there's something going, maybe it's just like really hard to lock that door and my kid just comes in anyway, or maybe, I'm just so overwhelmed at work. It's really hard for me to not instant message my boss. I mean, sometimes it's a clinical issue. And I think there's this moment and this opportunity to use our good skills as clinicians to take cues from the environment to understand what's happening in our patient's world. I encourage everybody, as we revisit the terms of this agreement, to document that conversation, document, where things went amiss, not just for risk management, although yes, for risk management, but also for our own use. Because, frankly, if someone has a minor disruption, they're on their phone or something like that, is it the biggest deal, one time? Well, maybe not. Am I going to remember the next time, if I thought they were looking at their phone a little bit? Maybe not. But if it starts happening every session, that's an issue. So that's why we call it out when it's happening and we document when it's happening, because these little things are additive and meaningful over time. And if we document it, we don't have to just rely on memory to know if someone was like, sneaking peeks at their instant message. We remember like, oh gosh, this has really been a thing for my client. And there's an opportunity for us to have this, a little difficult but important conversation. And again, I think of this as an opportunity for us to revisit the terms of our agreement, potentially to update our agreements and to update our documentation to reflect the realities of what needs to happen, and to use our own good clinical skills, non-judgment, curiosity, collaborative exploration, and problem solving, which is, conceptually what we're all about in psychology.
I love that. And I think it's so important that we can think of these as difficult conversations or challenges, but we can also take them as they are of, hey, I just saw this happen and, what's going on? What can we relate to in today's conversation? We had a question in the chat that really is relevant for not just thinking about kind of the clinical therapeutic interaction, but what about a virtual assessment interaction? And, we've got a different consideration perhaps there in terms of,
That's higher stakes poker. It is, because now we are outside of manualized guidelines. We are outside of administration recommendations. So I think, but I take it, all with a grain of salt. To some extent, this happens in testing. Things don't always go to plan. And what we typically do is we document what happened. We're clear in our report, any deviation from standard implementation. And we've talked in prior chats about, the challenge of teleassessment generally. Yes, there are tests and psychometrics now designed for remote or online implementation. That's great. They're normed for that. That's great. That's not every assessment, not every metric we have. And indeed, many times, and especially during the pandemic, but still today, we're having to be creative in adaptation, provided there is a good and legitimate reason to do so, to make sure that we are getting the right assessment to the right folks. That being said, when we do something remote, when we do something digitally that wasn't necessarily designed for that implementation, it's a variation. We have to report it. The thing I want to highlight is, particularly in the assessment of youth, the impact of third-party monitoring, can be very meaningful. I mean, in many clinical circumstances, but I think that's an assessment factor that often comes up. So, we want to think about the impact of third-party monitoring. We want to document that it happened. We want to be very clear in our reporting. It's true that in some instances, especially if you have a forensic practice, any deviation from standard implementation can cause shenanigans for you down the line, can cause challenge to your report or the validity of the findings. And so, again, this is part of informed consent, especially if you have an assessment and especially if you have a forensic focused practice. We want to communicate those boundaries early and often, that we don't want to have those things happen, and it'll go how it'll go. But in our informed consent process, the more we can articulate those boundaries, the more we set ourselves up for success.
all great advice. And I hear from colleagues as well that some of these things are creeping into the regular face-to-face practice too, right? Folks bringing their phones, the phones are going off. They want to, attend with their child during their
I
assessment
saw that question
session.
too. That one's tough, I think, because I mean, I would take it on a case by case clinical judgment basis. I agree, there are moments where a child's attendance, maybe that's part of the issue. Maybe there's, of course, if it's family therapy or something like that, but sometimes that can be clinically relevant. Some babies just sleep, and that's so lovely, except we don't know the days they're going to just sleep and the days they're going to fuss. I mean, at its heart, telehealth is about access. So by my way of thinking, the more we can promote access, the more we can be flexible in our patients' lives to make sure they are receiving good evidence-informed care in an accessible way. That's what I want to do. Now, if every session my client brings her toddler and her toddler is, doing toddler things all over the room and she's unable to focus and unable to concentrate, and, now is this child could be repeating things from the session, I'm not comfortable with it. So I'm always in a balance of what I know to be good clinical practice, but just real life, humanity of trying to be flexible for my patients' needs and well-being. So I think we got to take it on a case by case basis. I've certainly had quite a few sleeping babies, in sessions, and I'm not seeking to end that practice. And, I want to have the difficult conversation, if it is meaningfully impacting our ability to do the work we're there to do.
I think that's a great lead in to answering another question that came in as you were chatting, and that's about maybe it's a new referral who you've decided might not maybe be the best fit for telehealth care. And, similarly, not every part of life is, fits for telehealth, even if it's worked great up until now, but maybe somebody's gone off to college and for lots of reasons that might not be the best fit for them. What are some of the recommendations that you have in kind of offering the various services that could be available that maybe a referral, maybe something else in terms of what that patient's needs are?
It's a great question, and I think it spans the gamut. And this is, this happens outside of telehealth as well. I've had folks come to see me for one area of concern that I'm competent in and trained in, and then they want to transition to a different area of concern, or something new emerges in their life where, if I'm candid, I think someone else might be better trained, or I feel not competent in. Hopefully it doesn't happen too often, but it has happened. So I think this happens in practice, and telehealth is no exception. So in the circumstance in which, and I can think of examples, college is a great example. Maybe they go off, maybe they're not, maybe it's pretty straightforward. I'm not licensed, and, I'm not able to deliver care, to them legally. Perhaps they are wanting to do a therapy that I think is better suited for in-person administration. Now, I want to acknowledge that from a data-driven perspective, and we've been very clear on this pretty consistently, there are not that many circumstances in which we feel, remote care is prohibited. There's not a wealth of data saying, well, you can't do this type of therapy and you can't do that type of therapy. The data just doesn't exist. In fact, what we have is a lot of data suggesting outcome equity across circumstances, across in-person and remote circumstances. That being said, each of us has to practice in a way we feel ethically aligned and competent to do. And as long as we're consistent among our clients, I'm allowed to say, and in fact, I will tell you in my own practice, I do say there are some modalities I don't like to work remotely in. As an individual, and I'm not recommending this for anyone else per se, but I don't like to do dialectical behavior therapy remotely. Lots of people do, and do it so well. It's not in my practice. That's not what I do. So, if I found that I felt that if it was with a new client, or even with an existing client, that was, what needed to happen, well, I'd have to be flexible and think about it. This is a case in which it is nice to have the option of an in-person office when and if we need it. I saw in there a question about negotiating for a mailing address, and perhaps we can come to that one in a little bit, but I always say, if you're going to do that, negotiate in coming in if you need it. Just, negotiate a space if and when you need it. I have a totally remote practice. It is very rare that I need it. And, I like having the choice. So, we can be flexible, we can make the referral, we can try to offer in-person care. I mean, are there instances in which no other care has been available and I've done my best? Yes. I don't like treating avoidance, avoidance focused diagnoses. So, if someone has agoraphobia, social anxiety, some of those themes where I think there's a lot of value in being in the rub of things, in the mix of things. I like them coming out of their house. I like them coming into the office. I've worked with folks who they live in such a remote part of the country, they can't get in-person care, and that's just what's happening. So in those instances, yes, I have worked with them, and we have made sure that our homework in between sessions has a lot of exposure time, and that there's high compliance on that, because otherwise, what are we doing? Because exposure is indicated in that treatment plan. So, we try to be flexible. If we're the only game in town and truly it's telehealth or bust, then we make sure that our clinical intervention, is flexible to make sure they're getting what they need. It's a bit of a obtuse answer. I hope I got there.
I think we covered a lot of ground there, so thank you. In terms of time, do you want to jump into our next topic area in answering some of the questions we've had related to supervision?
That sounds great. So we
Right.
received a lot of feedback last time about supervision, and we thought we'd just take a few moments to dive into some of the fundamentals, which we've done deeper dives on prior chats. I'm going to keep that pretty succinct and then get to some of the questions we've received. So supervision, this is again just generally defined as this interactive educational experience between the intern and the supervisor. And this is an evaluative hierarchical relationship in many ways that involves training, extends over time, and it's with the goal of enhancing the professional functioning of the trainee. Telesupervision refers to the supervision of psychological services basically done through telehealth technology. So this is supervision that occurs through synchronous audio and video where the supervisor is not physically in the same location as the trainee. And this is a little bit different from in-person supervision where people are in the same location. And I want to draw another distinction that it is different from supervision of telehealth, because I find that people use the word telesupervision both to refer to remote supervision of a trainee as well as the supervision of telehealth itself, which could be done remotely or it could be done in person, but they're different constructs. So, when we're doing telesupervision, we're supervising a trainee at a distance. It's notable that the same benchmark competencies, and these are pretty well articulated by American Psychological Association, of supervision applies. Plus now we're needing to have awareness of, telehealth, the competencies themselves, because there's something very meta about that moment. Not only am I supervising my trainee, but I'm doing it at a distance, which requires me to be cognizant of the issues when we work with folks over a distance. So, I think there is this opportunity for us to reconceptualize how we think about didactics. When we are telesupervising our students, there are different opportunities than there used to be. First of all, we can be recording our sessions. If we are supervising telehealth activities, we can have our trainees very easily recording. I don't know about you, Margot, but when I was training, getting that video was hard. There was a lot of videotape, there was a lot of camera, there was a lot of shenanigans. This is all done much more easily in telehealth contexts. Supervisors can more easily observe sessions. Supervisees can more easily record. It also, more than ever, makes the issue of informed consent, making sure that we're capturing informed consent appropriately and that we have permission for recordings. It's just done so easily with the click of a button these days that we need to make sure we're alerting our trainees to these considerations. So, I think one of the things I really wanted to highlight is some of the awareness of, rules that govern telesupervision and some of the changes post-pandemic. In the past year, there are pretty notable changes in the Committee on Accreditation. They publish our standards on accreditation for training programs that have resulted in increased flexibility in the use of telehealth in education and telesupervision. So this is really important because it very much legitimizes telehealth, frankly, as well as distance education, but that's another issue. And I encourage anyone to read those implementation regulations. But more or less what I want to highlight is there's an increasing emphasis on saying it is legitimate for us to use telesupervision in the training of our trainees, but we need to have a why. The recommendations from those implementing regulations suggest an explicit rationale for why we're using telesupervision instead of in person. And I like to stay in my pajamas is probably an inadequate one. How telesupervision is consistent with the overall aims of the training program, how and when telesupervision is utilized in clinical training. And there's a real emphasis on thinking through which supervisees should participate and why, how the program ensures the relationship between supervisor and supervisee are established at the onset of the training program and maintained, and how that offsite supervisor really maintains full professional responsibility for clinical cases. So that includes things like crisis coverage, non-scheduled consultation, and that includes making sure that the privacy and the confidentiality of patient and the trainee are maintained throughout that context. So I think it has really fleshed out these requirements and helped, I think, programs understand this opportunity to make sure our didactics, know that they can use telesupervision and how to do it well. This is a big deal because I think it really, provides guidance for programs that would like to do this. It's more nuanced and a very reasoned approach to telesupervision. A question we've had along those lines quite a bit related to SIPACT, again, that interjurisdictional compact and telesupervision. So a question we had last time was like, well, hold on, I have a SIPACT credential, so I can practice interjurisdictionally. Can my trainees do that? And I understand why someone might think that, because as we know, our trainees practice on our license and, that might be a logical extension, but the answer is no. There's been, this was hotly debated last fall, I think, or so, thereabouts. And SIPACT regulations, the wording was changed to be very clear that the authorization to practice interjurisdictional telepsychology applies only to the credential holder. So all those requirements that you just articulated, Margot, that people go to great lengths to document and apply for, applies only to you and not to your trainees. So your supervisees cannot go into other jurisdictions on your license, which I think you should have us all, as we were talking about, there's a lot of responsibility, in terms of that cognizance and that awareness of regulatory differences between jurisdictions and so forth. I'll also mention that there's a variation in rules governing supervision among jurisdictions. So that would add another layer. But, the meta message here is nope, trainees cannot use your SIPACT credential to see patients in other jurisdictions.
And just to add on and emphasize, if your supervisee is in another jurisdiction, you have to really be cognizant of what those supervisor responsibilities and requirements are for that other jurisdiction, related not to them practicing through a SIPACT credential, but related to you providing a supervisory experience for them.
Supervision itself, falls under the rubric of the practice of psychology, and there is variance, among the jurisdictions and how they treat that in your ethical and legal obligations to a supervisee and how we are to respond to diverse circumstances. So it's another example of any time we practice psychology interjurisdictionally, we want to be very, very cautious, careful, and thoughtful, and really ask why. Why am I doing this? Is there a necessary reason, other than I just didn't think about it, or convenience, and to document that and be thoughtful and to think through, a risk managed approach. I see a lot of great questions, and we probably have, 5 minutes or so left. Should we begin?
I have found one as you were chatting that I think is well worth bringing up today, and that is probably consistent to a lot of our telehealth chats. And the question is, am I correct in thinking that regulations that you all are helping us understand apply both when we are working as independent contractors for a company that provides telehealth services and when we're working in our own business private practice?
Oh my gosh, chef's kiss, great question. I swear this isn't a plant. This is a real question, but it's a question we hope someone asks every time. Yes, you are still beholden to those rules. What was it? Dr. Martin had said to us today and other times as well, you cannot delegate your ethical or legal obligations to another. You just cannot. And the really unfortunate thing that we've seen is that there are those entities, companies that have suggested otherwise, that have said, don't worry about it. We've got this handled. You know, we will take care of all the ethical and legal considerations. You don't need to think about this. Maybe they do a good job, maybe they don't, but the practical reality is, you know, that as a license holder within a jurisdiction, you are beholden to the rules. And so you hold the liability and you cannot defer that liability. I've even heard of companies that say, well, we're going to have you practice interjurisdictionally, and if you get sued, we'll cover the legal costs. So there's no risk to you. You know, meanwhile, they could lose their license, they could lose their livelihood. You know, it is not up to the telehealth company to determine whether or not a clinician is licensed. That's, you know, that lies with the regulatory board. And so the licensing board. So, you know, I think that there is the ethos, and I don't mean to be negative, so excuse me, I'll walk it back a little bit. I do want to acknowledge, you know, a lot of these large scale telehealth companies are seeing a national crisis, tremendous demand, and the need of their fellow humans, you know, and they are seeking to meet that need. It comes from such a lovely place, but they may not have awareness of the depth issues and liabilities, you know, inherent to the practice of psychology and other mental health disciplines.
And licensure is individual to you as a eligible candidate for licensure. It has nothing to do with the organization you might work for or be employed by or 1099'd by. It is up to you to maintain that. It's up to you to make sure you know what your CEs are to maintain and renew it. It's up to you to have your liability insurance in place to manage anything that might come up. And anybody that suggests somebody else has a responsibility for that is really, I think, very much not looking out for you as an individual and your best interests as a professional. So I think very important to take those.
That liability coverage thing, you know, where this is in the context where, you know, we're talking from American Insurance Trust today, you know, like we believe in the value of good liability coverage. And it is the case whether you work with a telehealth company, whether you work with a hospital or an agency. When someone says, well, don't worry about it, we've got your malpractice covered, that's a question. You know, we should still ask questions. Well, what are the limits? What are the terms? You know, it is still our responsibility to understand what our coverage is and what our liability is, because at the end of the day, it's my license and my liability.
Yes. And, you know, I've always thought of it as the person who pays for it is the person with the coverage. And it's held very true to think about circumstances where even in a group practice that someone might have some challenges that aren't yours, but you might no longer be able to have that same liability or even healthcare coverage from that practice. So very important to think about these things. Do you see any other good questions?
Oldie but a goodie. It comes up, you know, every few times, and I'm thinking like, I think we could answer this succinctly, so I'm picking it. We had some questions about international telehealth. I think in this case into Canada, and it's a great question. And unfortunately, there's not a great answer for it. So, you know, as of now, international telehealth, you know, necessarily involves practicing outside of our licensure. You know, and when we practice outside of our licensure, inherently, we run into challenges with malpractice coverage. You know, we run into challenges with were something to happen, we don't have a great leg to stand on when we were practicing where we weren't licensed, which is, you know, at the foundation of all these other themes we're talking about.
And sometimes it's tricky to figure out, right? It's, you know, there might be a specialty that folks are seeking you out for. There might be a circumstance that, you know, your client's moving to that international location. And all of those things, I think, are great things to be curious about and ask questions about and really understand what your risks and liabilities are. And you may make a determination in your circumstance, in your situation, you're willing to take on those risks, or you don't want to take on those risks. And that then informs the next steps in terms of helping that person or entity receive the care that they need. So we've had so many great questions and
Thank
look
you.
forward to bringing those to our future chats.